Let me start with Dr. Sarabjit Chadha, who has recently joined FIND as the Regional Technical Director based in India. Professor Keertan Dheda from the University of Cape Town. Dr. Titus Divala from the University of Malawi. Dr. Hamidah Hussain from IRD Global. And last not least, Dr. Nestani Tukvadze from NCLTD in Georgia. Thank you, everybody, for joining us for this important discussion.
Can I ask, first of all, for just the panelists to address where do you think your top 3 priorities are for systematic screening or case finding in your own country? And I think, let's, if we can put those on the table first of all, and then we can manage a discussion around that. Nestani?
So, with respect to targets for active case finding?
Yeah, your top 3 priority populations or clinic.
So, in Malawi, the national program recognizes the key priority populations being the contacts of TB patients and close contacts as well, and also those patients that are in people that are living in high density urban centers, and also populations that are patients that are presenting to health facilities, and people living with HIV presenting to clinics are also promoted by both the HIV program and the national TB program. So those are the sort of high priority populations in Malawi.
I think it's quite similar in India. India is a high TB burden country, and what we've seen is, that the urban slums, household contacts, and prisoners, are the 3 top priority groups. But of course, India being a large country, there is also a lot of variability in terms of prevalence of TB, and so the scenario changes. It also depends, how the transmission is happening and what are the healthcare services available. So it may not be like written in stone that these are the top 3 groups, but these could probably change, with province to province or district to district.
I don't know if this is working. Yeah, so I think I had pretty much the same 3. I put community-based active finding in these peri-urban informal settlements or slums as number 1, because that's really where the bulk of the missing cases are, and that's where most of the transmission is happening. Second was healthcare facilities, and thirdly I put down contacts of index cases, but I think focusing on this community-based burden is a priority because that's where all the transmission is happening, and if we're really going to impact the epidemic, that's where we need to be looking. I mean, you raised the question of what diagnostics, what do we do now, and what do we do later on, but I would just like to suggest early on to park this for discussion later. Maybe we should be talking about embracing a new paradigm, and that's taking the diagnostics out into the community. And, in the HIV field, we have HIV self-testing. Why can't we think about TB self-testing? And Claudia mentioned in the context of the existing diagnostics, the different levels. But maybe beyond level 0, we need a level -1, right? You take the diagnostic out into the community. It's available in supermarkets or kiosks, in pharmacies. You can buy it, and you can go home and you can test. Okay, and I think some of the, if you look at Claudia's, listen to her talk, some of these things are now tangible, right? These lateral flow assays and the signatures on simple platforms. You can, it's tantalizing, but you can envisage a scenario not too far into the distant future where you could buy such tests. So I think the paradigm would be moving diagnostics out into the community. The question is, how do we do that now? Do we use things like Expert Omni and other things, and CAD, as you said, and what do we aim for?
Yeah.
So in Pakistan, we follow pretty much what you guys have already discussed, so I'll not repeat that. What I would like to add is, as IRD, what we have tried to focus on is make facility-based screening our priority. And those are low-hanging fruit. People are already approaching the facility for symptomatic care. So including patients as well as their attendants, whoever is coming to the facility. Then, of course, contacts are our second group that we have really focused on, and then the vulnerable population, both in the industries and the prison systems and other people living with HIV.
Yeah, good afternoon. The WHO recommendations are clear. We all know what are the groups. In Georgia, they are the same: PLHIV, household contacts. We do prisoners as well, although it's not very highly recommended. There is not that much evidence behind it. But what I want to say, so when we do household contacts, the total percentage out of all notified cases is 4%. When we do prisoners, in the prison sector, the notification rates are much lower. In Georgia, it's different than in the civil society. And then PLHIV, we're a very low HIV burden country. So what's the total yield of what we're getting from this active case finding? Probably it's very little. So what I wanted to say, it's really second the professor, what was already mentioned. We do need to do some active case finding within the community, and we need a non-sputum test, which will help us for screening.
And in terms of, I'd be very interested to know people's opinion about using the more sensitive, so the more sensitive tests, such as Expert Ultra, that carry with them, a risk of overdiagnosis for a screening context. So anyone with experience of using them, I mean, is the panel comfortable using the Expert Ultra for a screening purpose?
Georgia is one of the sites for the FIND trial, so we were one of them who participated in the trial for Ultra. We have not used it for the programmatic use so far, but what are my thoughts? So if we want to use it as an active case finding tool, we need to bring it towards primary health care, right? So primary healthcare facilities, there are around 5,000 facilities in a country like Georgia, and the total number of notified TB cases around 3,500. And we're still high TB burden country. So how we can do it in the reality, right? If we have the healthcare facility which has total beneficiaries like 500 person or even 1,000. Do we expect any TB suspects throughout the year? We don't, taking the notification rates we have in the country. So we need to be very careful, probably. That's a very good tool, very highly sensitive, but where we place it and how we do it, that probably needs to be done very carefully. So what we have seen from this test, really a better sensitivity, which is wonderful, but specificity a little bit sacrificed, right? And if we're using it in the primary healthcare, again, what we're doing with the false positive results, and do we want the confirmation by TB specialists or specialist TB services? Probably yes. So there needs to be certain algorithm behind it, how we will be using the test results. So that are my quick thoughts right now behind it.
Yes.
So we are using Ultra right now for active case finding. And I think there are two parts to answering that. The first part is the trace results. And in South Africa at the moment, the trace results are reported as an indeterminate result. So we refer those patients to the clinics, which is an easy way out. But I mean, as a clinician, you're faced with a patient and you have to make a clinical decision whether to treat or not. And that's very difficult, right? Yeah. So you do the usual things, chest X-ray, antibiotics, and you're still not sure where you are. But that's the trace results. I mean, the other challenge is obviously you're going to have with any test. That's the issue of prevalence of the disease in the population. Yeah. So I think it depends where you're using the test. With the pictures you showed, with the populations we deal with, the prevalence of TB in the general population is 1, 2, 3%. It's staggeringly high. So I think in that kind of population, though there might be some overdiagnosis, I would treat in that context. Obviously, if you're doing active case finding in a different context, where the incidence of disease is different, depends on the follow-up of your patients, then you might seek some type of confirmatory testing. Question is, besides culture, how do you do that confirmatory testing? Do you do it on a clinical radiological picture or a biomarker like CRP in HIV? That's unclear. But that's how we're dealing with that right now.
Right. So, in India, we're not using the expert ultra for active case finding. But I remember, a paper by Kendall, Claudia, and Dowdy, where they did a modeling exercise, taking India, China, and South Africa. And I think what is important to consider is that when we say overdiagnosis, what is the risk-benefit analysis, and how many deaths you are actually averting? So if you take various communities with different levels of TB prevalence, definitely the one with lower prevalence, you're going to get more false positives, and the aversion of deaths would be much less. But as soon as the TB prevalence increases or the HIV prevalence increases, the number of deaths averted would definitely be more, and the number of false positives would go down. So I think it's a trade-off, and it's not very easy to confirm every case doing a culture or a biomarker or other things, and to live with it.
Let me just add that in addition, expert ultra is looking good in terms of sensitivity, a good screening test. But then one aspect, in addition to the false positive issue that has been discussed already, the other aspect is how much is it going to drive the cost of the screening program upwards. In my country, for example, our GDP is around 360 per capita, and our health spending is $25 per individual. So if you look at that, you bring in expert ultra. I think we probably will also, in addition to looking at the evaluating expert ultra in active case finding studies, we also need to do detailed cost-effective analysis to see whether it can really fit at that stage.
I just want to make one more comment on this. I would encourage a lot more studies using ultra for active case finding, because we really don't know about this biophenotype in the community, right? I mean, from an evolutionary perspective, as an organism, TB would want to propagate itself, and so you get this phenotype of patients who have minimal or no symptoms. In the exact one RCT, where we put expert on a van with a generator and went out into the community, a third of patients who had minimal or no symptoms were smear positive. And in the current randomized controlled trial we're running, we're seeing the same thing. A third of these minimally symptomatic or asymptomatic people actually have cavitary disease, right? So what is the strain type? What is the immunological profile in these patients? We don't really understand that. And so I think we need to biophenotype, and we don't really understand what's happening in the community. But the reality is that, 2 out of every 10 patients is missed. They're out there in the community. So we better start doing something to find them.
Yeah. Can I just, since we're a bit short of time, can I just quickly, so another couple of questions that I'd really be keen to know, which you've just touched on. So how far do we go in terms of letting symptoms guide us? So, I've suggested that we do use symptoms to guide in most settings once we're at primary care level or below. But of course that does then ignore patients with asymptomatic disease. So how important does the panel think it is to find those patients?
So in using symptoms as a guide, currently the most recent guideline, which is about to go into operation in Malawi for the National TB Program, the symptom screen is sort of classified into various categories. So there's a group where you have to look at 2 weeks of symptoms, and then there's a group where you have to look at 1 week of symptoms and any symptoms. So depending on the risk, for those that are HIV negative and they're presenting to the health facility, the national program is now working towards saying we should use a 2 weeks cutoff, because otherwise we'd have a lot of patients coming in. For those that are a higher risk profile, then like minors, healthcare workers, those are going at a different cutoff.
So again, it's a bit inconsistent to have a lower standard in the community when you're applying in the clinic. Maybe that's a sort of good guide.
Yeah, I mean, I think the issue of symptoms is a challenging one. Look, I mean, with the populations, certainly in South Africa, really we should just be screening everyone, right? I mean, you don't want to make symptom as a cut when you're dealing with this prevalence of TB. However, right now you can't, right? So you have to decide how to make the cut and how to triage and how to target. So the approach we would currently use is certainly in HIV-infected persons, symptoms are quite unreliable. In fact, there's several studies that show with the kind of HIV prevalence we have that you miss about 20% of patients. So there we don't use symptom screening. However, for HIV uninfected patients, it's not ideal, but we apply a symptom screen. And then we would do something like ultra with sputum induction. And again, you know, it's debatable how you proceed. We don't really know, and that's what we need to work out.
Yeah.
So, you know, for the low HIV prevalence settings like India, I think what's important is that the symptoms can be a good guide. It depends on the duration and the severity of illness. So patients who are actually going to the health facility are suffering from some kind of a morbidity because of this disease. And if you use symptoms as a guide, it works well. And not just only cough, but if you use a syndrome, you know, maybe fever, night sweats, loss of weight, it actually increases your yield. But when you talk about active case finding at the community level, we lose out on 20-25% patients, you know, who are asymptomatic but have chest X-ray lesions and ultimately turn out to be expert or culture positive. And there I think we need to be very careful because it's a very resource-intensive exercise. And it's an opportunity cost. Once you're going to these communities, and if you're not doing the entire diagnostic, you're not following the entire diagnostic algorithm, you're actually missing out on 25 to 30% cases.
Right. I think I agree with what our colleague from India is saying. In our experience, it's exactly the same, that those coming into the facility, if you do the X-ray immediately, which is accessible, your number needed to screen is much, much lower. In the community, the number needed to screen goes higher, much higher, but we need to do it. If we are to achieve the numbers that Liz, you were presenting, there is no other option but to do that. And we should think about taking X-rays to the community and not really relying on symptom screen at that point in time. And I think there are studies which show that if you do this, you do get the patients that are undiagnosed and sitting in the community, and that will affect the transmission.
Just to comment on cost, I mean, that's the biggest challenge we face, right, with governments. If you say to them, well, we're going to put ultra on with us in a small mobile clinic, and they talk about cost all the time. So I think we need a lot more advocacy on putting this cost into perspective. We all know it's cost effective, but it's affordability, as Jim mentioned early on, that makes a big difference. And if you actually look at the KPMG report, I mean, TB hits the GDP of many African countries by between 2 and 3%. In South Africa, that amounts to like $10 or $12 billion a year, right, which is about a third of our entire healthcare budget, just on one disease. And in many countries, it's half the entire healthcare budget, if not more. So I think we need a lot more advocacy to politicians so that they understand what is the economic cost of this disease. And I think that's going to be very important for governments and politicians to understand the economics of active case finding and why they really need to do it and why they need to spend money on deploying these tools that you mentioned in your talk.
Yeah, I would just underscore that. I think the economics, the health economics and mathematical modelling absolutely vital, you know, to be fitted into all studies and communicated to policymakers, because that is what they understand and respond to. Again, we had enough to cram in. I was hoping to get some economics in, but didn't. I'd like to just leave a little bit of time for questions from the audience. But just any other kind of burning points from the panel that we haven't touched on?
So I would just like to make another comment. Active case finding is actually viewed like a prevalence survey. You go, you do your chest X-rays. You're calling people, going to their houses, bringing them to the mobile vans, testing them, and leaving it. What's important is that active case finding needs to be complemented with enhanced case finding, where you're also creating awareness about TB among the community. And we've seen this in India, where we did active case finding in 300 districts. It was not just that intervention, active case finding intervention per se, but in the following 6 months following this intervention, a lot of patients actually came to the health facility saying that, we got information about TB. And that's how we are going to invest less resources and get more yield. It's like a continuum that's going to happen. And that needs to be stressed upon, that it's not a prevalence survey, it's an intervention.
There's one other population subgroup we didn't mention, as was mentioned in the PK session this morning, was pregnant patients. Pregnancy is quite common. And the number one cause of maternal mortality in Africa is TB. So that's another group that I think, and in South Africa, through the National TB Think Tank, there's a recommendation that all pregnant patients be screened for TB. But I don't think we've got time to discuss the nuances of that.
I also have a bit of a bias in that we've done quite a lot of work showing that prevalence is twice as high in men as it is in women, but they're just a very difficult group to advocate for resources.
They're not difficult.
Pregnant women are easy to raise money for. I think we can all agree on that.
I just wanted to pick up on the point of active case finding, that once we do the active case finding, we need to ensure that our labs have enough capacity to absorb the number of cases number of patients that are going to come in for testing, and lab strengthening should go hand in hand with the active case finding.
Yeah, just to add to that, we also need to bring another important point along with the same is to bring the confirmation closer to the active case finding, because we can do the active case finding and lose patients along the way. So it should be as close as possible to the screening. Thank you.
Can we take some questions from the audience? Yeah. Just try. Do you want to speak? Here. Do you want to take this one?
Thank you, Liz. Madhu Pai from McGill University. A quick comment that active case finding is important, but there's at least 7 countries, and we call them the Big 7, with massive numbers of missing millions with phenomenally privatized healthcare. And we had a 2-day meeting on how critical it is that if you want to find TB in these countries, India and Pakistan is right on top, Bangladesh, Nigeria, Indonesia, Philippines, and Myanmar, the easiest way to find your missing millions is to go to the nearest private doc who's managing TB. And if you have that, there is no lower hanging fruit than that in finding the missing millions. Instantaneously, you will find TB, you will get them notified, your numbers will jump up, and you can work with them on improving quality of care. And so when I'm faced with the choice of getting on a van with the expert and an X-ray and running all over the place door to door versus going to my nearest high-volume private docs and finding TB, that thoughtful decision should be made by a country, because ignoring that massive private sector is disastrous, because that is where the gold lies in the immediate term. Then in the longer term, you can do. I'm not saying it's either or. I'm just saying which country you are working in must drive that decision making. Thank you.
Yeah, we did refer to your work earlier on, actually. So, I think that, and I would agree fully. anything you do at community level, it has to be strengthened at facility level first. Those were lessons we learnt from the 1980s, and it defeats the purpose completely without that.
Thank you. I think what Madhu is saying as well is that it very much depends on the context of the health system. Because if you have a very good health system that everybody has accessibility to it, then there are not so many missing cases. So it depends very much how the services are, how strong they are, how accessible they are. And I also think what you are saying here, active case finding, you are saying very often, we go there. I think what we are really saying here is that the services should extend to the community and be there, not accessing them, not accessing the population, be within the population. And therefore, if you have a community health extension program that reaches the population and is embedded there and is, I would think, salaried, that's a very different context than if you do camps activities or so on. And I just want to build in another important question. No, it's not only reaching the people to diagnose them, it's also linking them to treatment. And many of these activities, what we have found is that we have very poor linkages to treatment. And in that case, you may invest a lot of money to find them, but you are not making any difference because there is poor linkages to treatment. Just to finish, the TB Reach is a 120 million initiative, and you quoted several examples of that. And they are synthesizing all the evidence of what has been learned over the more than 150 studies that have been funded over the last 5 years. It will appear in the spring. So it's a very good base for many of these lessons that you are highlighting, and it's in a very wide geographical spread.
Sabira Tehseen from Pakistan. My question is regarding the active case finding, and my concern is not putting patients who are trace positive on TB treatment. My concern is regarding patients who are tested on CAD4, who are tested negative on expert. How much proportion are then put on treatment, empiric treatment? And what is your experience of what is the proportion of patients being put on treatment who are expert ultra or expert MTB-RIF negative, who have some evidence on the X-ray? Yeah. So because my concern is that the country estimates are based on the prevalence survey, and the prevalence survey's estimates are based on bacteriological diagnosis. So if we are putting patients who are not bacteriologically confirmed, probably we are putting patients, this was not the populations which were estimated in the survey. So this is additional population which we are putting on the treatment.
I agree.
And we are missing more cases than we are.
If anyone from the panel has a,
Yeah, so I mean, the reality is, in South Africa, like many other countries, only half the TB we treat is microbiologically proven. But it's the same in the UK, which arguably has, no major limitations in accessing resources and investigations and so forth. So, I mean, that all goes to the earlier talks about the need for a sputum-independent test, right? So the fact that we don't treat half without microbiological proof, empiric treatment, there are many reasons for it. One is the lack of a test that can tell us about extrapulmonary TB, those people that are sputum scarce and so forth. And I think that's the big challenge. So while with ultra the sensitivity has improved, though there's some other drawbacks, we're still not quite there. We still need better tests.
So I think if that feeds into the question where, as we're scaling up, new diagnostic needs are going to arise, and that's where I'd really like to see us sort of generating new diagnostic TPPs, etc. Is as we start to scale up screening, what are those additional confirmatory tests or triage tests that we need alongside? Just in the interest of time,
So, I think the effort needs to be made in terms of trying to get a diagnosis, a bacteriological confirmation, and with X-rays, with expert coming in, I think this has improved. And so the proportion of those actually treated empirically has gone down, and there are studies which show that. the exact proportion is not known. It could be 20 or 30% reduction. Because now it also compels or forces the physicians to think of an alternative diagnosis since your expert is negative.
Thank you, but at the country level, I don't see it happening. I still see the empiric treatment rather has gone from 60% to now to 62% with all new diagnostic coming in. So there is a lot of pressure on aggressive case finding, but also on aggressive case notification, and we are just putting probably too many patients on empiric treatment.
May I just ask, I mean, I completely agree that we need to use diagnostic tools in screening situations, because a lot of sensitivity, specificity estimates we have are essentially from diagnostic populations, so from passive case finding. So as you said, we need to see how Expert Ultra is performing in mass screening or in certain screening populations, but we need to see that as well for CAT4TB or for any other kind of computer-assisted reading, because what you have, most of the computer-assisted reading studies from digital chest X-rays are actually in the kind of context of diagnostics. So it is a passive case finding. There isn't that much in the context of mass screening, where you're obviously seeing different kind of populations. They have different background morbidities. And I think it would be extremely useful, as you said, community-based screening is nothing else than a prevalence survey. And we have huge amounts of prevalence surveys where we where we use digital chest X-rays. So they could be reanalyzed using different computer-assisted reading, which would help us greatly to understand what is actually the cutoff we should use, for example, in a mass screening campaign for CAT4TB. Because I do agree we need to have actually WHO endorsing these computer-assisted reading, because that's often the bottleneck of doing chest X-rays is you have nobody who can read them.
We are trying to build a panel of chest X-rays from kind of the diagnostic use setting that Katharina was mentioning and the screening use setting to define how good different CAT solutions are working, and this data will be presented to the WHO early next year. And thank you to all of you who have contributed chest X-rays and who are considering to contribute chest X-rays to this panel. Thank you very much.
Okay, so I think we have time for one last question before we move on to the next panel. We do have time for one. Okay, so I mean, well, I'd just like to thank everyone who's participated, the audience for coming, and I think it's nice to see again such kind of harmony about priority populations, who we're wanting to screen, how we're wanting to screen, and the questions that are coming forward. I do think we have to do more screening, and that the diagnostic questions are going to be very different. And will have to be tackled kind of as we go along. I do also agree that there's a real danger of, if you like, human rights abuses, and I think we've got some, there's some sessions on that in this conference. So as you start screening, it can become a bit coercive, and again, there is always that need to really guard against not doing more harm than good. And that has to apply not just at the community level, but at the individual patient level. And I think, that's something that HIV world knows very well, and if anything is a bit too strong about. Whereas TB, I think we're used to putting the community ahead of the individual patient in that respect. So I very, very much agree with that point.
I'd like to thank very much all the panelists. It was a very interesting discussion, and in particular, I like to thank you, Liz, because not only for your great presentation, but because you really addressed the discussion in a very, very productive way.